Thank you so much for joining this pre-recorded webinar from the Kentucky Regional Extension Center. My name is Jessica Elliott, and I'm one of the advisors here. Today, we are going to talk with you about the QPP 2024 Year in Review Roundtable. Now, before we get started, I just want to go over this very quickly. The information contained in this presentation is for general information purposes only and does not attempt to provide medical, mental health, or any other type of healthcare service. This presentation is not intended to be an alternative to medical treatment, and the content of this webinar may not apply directly to specific circumstances. The information is provided by UK Healthcare's Kentucky Regional Extension Center, and while we endeavor to keep the information up to date and correct, we make no representations or warranties of any kind, express or implied, about the completeness, accuracy, reliability, or suitability with respect to content. And here are the REC advisors, several of which are going to be presenting with me on this particular topic today. We just wanted to talk with you about some of the work that we do here at the Regional Extension Center, in case you aren't aware. We do work with a significant amount of practices, hospitals, healthcare systems, and individual clinicians across the state. We also partner not just with our fee-for-service work, but we also partner in quality improvement, EHR implementation, promoting interoperability, and other initiatives. And with some of our grant work, we have actually been able to administer over $40 million to our providers and practices across the state. So again, we encourage you to, if you see any grant opportunities, if you see any of our fee-for-service opportunities as well, we are happy to partner with you. Not just a part of the quality improvement program or value-based payment. We do offer services around PCMH and PCSP, the Promoting Interoperability Program for hospitals. We also do HIPAA, SRA, privacy and security and vulnerability scanning. So a wide array of services that we can provide to your organization. Now, on the docket for our conversation today, we are going to do a brief overview of the MIPS value pathways and just overall QPP eligibility. We're also going to dive in a little bit more around highlights to quality and the cost performance categories. And then we are going to speak on some of the transitions and the preparedness overall for advanced alternative payment models. These are some of the arcing themes, I should say, that have come from CMS's final rule for 2024. We're getting ready to wrap up that year, and we're actually looking at their final rule that was recently released for 2025. And then additionally, we're going to end discussing some audit support and some of those things that we need to do to dot our I's and cross our T's as we put performance year 2024 to bed. So this is just a high-level overview of the quality payment program. It starts out in a couple different tracks. We have traditional MIPS, and that is what most of us are used to. The program came into play in 2017 after the sunset of a couple previous programs that had been in place. And so this is truly, we have a very wide menu of measures and activities to choose from. You can sort of pick your own measures. CMS over the last few years has introduced the MIPS value pathway, or MVPs. This is going to be a very focused, limited measure set, both quality and improvement activities that align closely with a particular population, episode of care, or disease condition, very much more specialty-based in its reporting. And this is truly the future of staying within the MIPS track of the quality payment program. Now, the other sort of half of the QPP is going to be your APM pathway, or the APP for short. These are for MIPS, APMs, and even some advanced alternative payment models for those folks who don't meet that full criteria. And this is a specialty measure set that aligns with the objectives of an ACO. If you are participating in a Medicare Shared Savings ACO, your ACO participates in that APP track for quality reporting. And then finally, we have the Advanced Alternative Payment Model. These are these are full capitation, full risk APM contracts and arrangements with CMS that have that full upside and downside risk. If you are what they call a qualifying participant in an advanced alternative APM model, you would be MIPS exempt from the program. You still have reporting requirements around quality and other objectives and measures through your advanced alternative payment model, but that's a part of that contractual arrangement. All righty, so digging into kind of comparing and contrasting traditional MIPS and MVPs. There's several different, implementation considerations that you really need to be able to look at to decide how you're going to participate in the quality payment program in the future. That was really, I feel like, the theme from 2024 is trying to identify how you're going to transition from this world of traditional MIPS over to MIPS value pathways.
Yeah, I'd like to start with that, Jessica. This is Robin. Thanks for everybody for joining us today or watching our webinar. So when we look at traditional MIPS and MIPS value pathways, probably the largest difference is if you want to participate in an MVP, you have to register by a certain date. CMS gives us some flexibility with that. You have through close to the end of November, 1st of December to do that. So you have a whole year there to look at how your performance is before you make that decision. And then probably the next difference there that's pretty significant, I think, is once you decide if you are going to participate in an MVP versus traditional MIPS is the number of measures and how the programs work. Traditional MIPS is very siloed by the categories. There's no connection between quality and cost. Promoting interoperability is promoting interoperability. And then improvement activities, they don't necessarily have to match your quality measures. MVPs have a little more flexibility with that, and they're a little more limited on and are more focused around a specific disease process or specialty type thing.
Right, Robin. And this is Tab, guys. Glad you all joined us today. And Robin had just mentioned about, that it's a benefit that you don't have as many measures to report for the quality category and so on and so forth. But with MVPs, they're all focused around a specific specialty or diagnoses, or kind of built around different cost measures. So it really helps to align those activities and measures that you report and relieve some of that burden in deciding which measures best represent the work that the clinicians and the practices are doing. So with cost, you're going to have a handful of measures, maybe 1 to 5 that you could be scored on rather than all 29, which is much better. And with AI, along with that more focused improvement activity selection, you're also going to have more favorable scoring with only having to submit 2 medium weighted or 1 highly weighted activity versus the 4 medium and 2 highly weighted activities that you'd submit under traditional MIPS if you didn't have some kind of special status designation. So PI is going to be the same across all MVPs. It's kind of, the foundational layer across all of those. So you'll report the same thing no matter which MVP that you do. We do recommend that you kind of talk with your vendors and understand what they can support before you fully decide and jump into reporting MVPs, because some of them can support a lot more than others. They only maybe do a few measures where some might do the whole MVP inventory. So just want to check with your vendors on that.
And just to add to what Tabitha is saying, one of the common questions that we receive from our clients is, does our EHR support MVP reporting? And that's a good question. And that's kind of where we are moving to. And that's where CMS is really pushing organizations and practices to, is to transition to those MVP, to that MVP track. So, so if you're not sure that your EHR supports MVP reporting, then you definitely would need to reach out and ask that question, kind of get where they are on this reporting mechanism, what the status is, And if you get, if you get a confirmation of no, we're not, close, or we're not even having that discussion just yet, then you may want to start looking at qualified registries or QCDRs. And we're going to talk a little bit more about that in some upcoming slides. But these are definitely conversations that need to happen now with your EHR vendor. And then having that discussion about reviewing different qualified registries and different QCDRs that could actually be your reporting mechanism for MVPs.
Well, hi, everyone. This is Vance. I'll just step in here with this has been a lot of good information on some differences between traditional MIPS and, the MVP track. Some things that you might find challenging between these two things, and that I'll point out that's not been shared yet, is to also remember that for both tracks, traditional and MVPs, PI is moving to that different time frame. It's now 180 days reporting period. So that is a full 6 months, basically, of data that you will have to submit for that PI category. So keep that in mind. Another thing that you want to think about is the differences of the cost category between traditional and MVPs. So one of the advantages of MVPs is, it has specific measures that apply to that specific MVP that you are registering for. So cost is a category that you would only have to be scored on, just maybe a couple of different measures depending upon the MVP. Whereas in traditional MIPS, you have the potential to be scored on up to 29 measures if you meet those thresholds. So that's something to think about. You have a little bit more leverage and choice when choosing an MVP. Another thing to consider is, that the EUCs, extreme and uncontrollable circumstances and hardships. There's two EUC applications that are available. One is for the MIPS extreme and uncontrollable circumstances exception, and that allows you to request reweighting for any or all of your performance categories if you encounter an EUC that's outside of your control, such as something like Hurricane Helene, if that did hurt your organization. If you were in North Carolina, potentially that would be something that you may be able to apply because of that circumstance. It also would be because you're unable to collect information necessary for a certain MIPS category. And then lastly, for that type of exception is you're unable to submit information to be scored for a MIPS category for an extended period of time. So if you were unable to collect data for a quality category for 3 months or something like that, anything that's going to impact your normal processes that could be used to use that type of an exception. The other type of exception is that hardship exception, and that allows you to request reweighting for the PI category if you qualify for maybe a decertified EHR technology has happened, you have insufficient internet connectivity, or you have faced a disaster, your practice closed, something like that, or you have lack of control over your cert. Those are all reasons that you could, apply for that. Now, just because you don't have a required cert, that doesn't qualify you for reweighting. It has to have a reason for not having that. So just keep that in mind as you're thinking about these things.
Hey guys, this is Jared here. Thank you all for joining us. So I think our team has done a really good job, already in this presentation of showing off their expertise here. I'm talking about some of the technical aspects and specific areas to watch out for with MIPS, but I really wanted to talk about how the REC can help you with this process. So our team's really here to roll up our sleeves and get into the work with you. We can assist you with workflow changes and new workflow implementation around measures. We can help you audit and validate your data and really dig into patient charts. When it comes to MVPs, we can help assist in narrowing down the list of relevant pathways to make sure you choose an MVP that fits your scope of your practice. You could be in a situation if you're a larger organization where you might need to put practitioners into separate subgroups, and that's something we can help you do as well. You know, really with all pathways and performing through MIPS, we can help you with measure selection and make sure that you're choosing the measures that are most meaningful to you and that you can have the most success with. And so we're also really here to help troubleshoot any challenges that may come up with your vendors or any other areas you may run into with issues. So we truly offer a full service kind of at the elbow support for our clients. And with that, you know, talking about pathways, I think this is a good segue point into our next slide here, and talking about really how you plan to report your quality performance. So just like traditional MIPS, ECQMs, claims, MIPS CQMs are all available collection and submission types in an MVP, but there's a couple of different caveats for each one. So I'm going to call on Vicky here to kind of walk us through claims.
Yeah, thank you, Vance. Thank you, Jared. So who can report claims and what happens if there's only 2 claims in an MVP? So we can refer to the example on the slide. So for this specific MVP, there was only 2 claims measures that were available that could be available for an organization to report on. If you are a small practice, reporting as an individual or at the individual level or the group level or even at the subgroup level, and you're using Medicare Part B claims to report your quality, you only need to submit data for the Medicare Part B claim measures available. So in this scenario here, there was only 2 claim measures available, so you will only report for these 2 claim measures.
Hi, everybody. I'm Alicia. I just want to hop in here quick and talk about some of the flexibilities with your submission types. So this program actually does give you some flexibilities in how you report your data. You can report using all ECQMs, all MIPS CQMs, or all claims-based measures if you are a small practice. Or you can submit using a combination that suits your practice best. An example of this might be that you're a small practice, you have some measures available through your EHR, but you also want to submit a few additional measures using claims. Or maybe you're already working with a registry, so you have some of those MIPS CQMs available to you, but you also want to support a couple measures that are available within your EHR. I think it's important though to emphasize here that each submission type is going to come with its own unique benchmark and decile scoring. So really understanding what submission options are available to you and then evaluating which approach, whether that's going to be a combination or a single submission type, will give you the most favorable scoring. I think that's the key here.
I agree, Alicia. And when you're deciding how you're going to submit, whether it be, you know, either one collection type or a combination of those, even though there is more alignment when it comes to MVPs, there's still going to be some complexity when it comes to measure selection, and not really only with measure selection, but with the actual MVP that you're going to report. So obviously with MVPs, you're going to choose one that more revolves around the type of care that you provide. But what if you're a multi-specialty practice? How do you choose then? For PY 25 or performance year 2025, I should say, you can, as a multi-specialty practice, report all your clinicians within your group under the same MVP right now. However, in 2026, subgroup reporting, is going to become mandatory when you're reporting under the MVP pathway. It can be kind of overwhelming when you think about having to report differently than you normally have in the past, say those that have always reported under traditional MIPS. But even more so when you think about having to report multiple MVPs and then getting into this discussion of breaking that into subgroups. But I would say with that, one of the benefits of subgroup reporting is going to be that clinicians are going to be able to report those measures and activities that are relevant. So with that being said, there's not going to be as much muddying of the waters with regard to that data. It's going to provide a more integrated evaluation of care quality It's going to offer clinicians comparisons that are directly relevant to what they do. And we as advisors here at the REC are able to review your clinicians. And I know Jared touched on this just a second ago. We can look at your specialties, if you have multiple within your organization, and kind of do a comparison to give you options that make sense and could actually result in more favorable scoring because of that improved alignment between the categories. With the ECQM reporting in MVPs, I feel like with this slide, it's one of those challenges is going to be measure availability with ECQMs. And we saw in the proposed rule update for performance year 2025 that all the quality measures that were offered for addition were MIPS CQMs. And I'm curious as to what you guys think about the lack of new ECQM development and how that's going to affect clinicians and organizations that are reporting, for the future in the quality payment program.
So I think that the limited development and then the removal of ECQMs has really created a lot of challenges for many practices. Some of the ECQMs that were removed have now been grouped into a single preventative care and wellness MIPS CQM. But now that it's a MIPS CQM, it's going to require using a registry to report it. And then also some ECQM measures have been removed from traditional MIPS, but were retained for MVPs only. However, as we saw last year, even measures retained for MVPs are not guaranteed to stay available forever, as some of those were also eventually removed. And the lack of ECQMs impacts all practices, but it can be particularly challenging for specialty practices who already have limited measure options that are meaningful to their patient populations. So with fewer ECQMs available, more practices may need to consider registries to really kind of start to broaden the range of measures they can report and better meet their reporting needs.
So as you can hear from my colleagues here, we have several subject matter experts when it comes to quality reporting and ECQMs and measure selection. And I just want to talk about and reinforce how we help our clients with measure selection. And so we really get into things within your practice. We want to know how things work for you all currently, and then identify any areas of opportunity and help you strategize and pull down for those things. So we start with looking at your practice designation. We look at your EHR functionality. We already know that some electronic health records are moving into the MIPS CQM reporting because of the lack of availability for new ECQMs. This opens the door for more expanded measure selection. And we start looking at what processes that you currently have in place that may already satisfy some of these measures. We know folks are already working on like things such as public population health, maybe some more focused things within your practice that you're working on that we may be able to help you find measures with under MIPS CQMs and maybe other ECQMs. When we talk about workflow mapping, we help you identify whether or not your team is working to the full ability of their scope. This isn't all on physicians. It's not all on nurses. It's truly is a team effort, and we want everybody to be contributing to the best that they can. And then we also work with you on data validation. We put a lot of trust in the EHRs are doing what they're supposed to do, but we have seen many times that they're only as good as the information that's put into them. And, what may have worked whenever you installed that EHR may not be working now. And so we help with you with data validation and understanding what's going into your numbers, where the data is coming from, how it's getting there, and what you can do to improve on that.
So the lack of ECQM development really pushes this next conversation. And we did talk about it in a previous slide, and it's a discussion about QCDRs and qualified registries. And they are becoming more significant in the program each year. So connecting to a qualified registry or a QCDR allows the clinician or your practice to fulfill either track of the program. So kind of that's where your MVP reporting if your EHR vendor is not ready to report MVP, or if they've not become a qualified registry, and that's really where you have to kind of start digging into the registry listing, which can be found on the QPP website. Start digging into those registries and those QCDRs to reach out and get some information on on what they are currently reporting, what MVPs they're currently reporting on. And this kind of just helps you to kind of stay ahead of the game a little bit and get closer to that transition to MVPs when the traditional MIPS sunsets. Vance, can you tell us a little bit more on how the two registries are alike?
Sure. Thanks, Vicki. So a QCDR and qualified registry, two things that are similar about both. They both are considered CMS approved third-party intermediaries, and they both can collect MIPS data from your MIPS eligible clinicians and submit to CMS on your behalf. So those are the two things of how they're alike. And so I'll defer to Jared how they're different.
Yeah, so I'll talk about how they're different here. And there's really a couple of main differences. The first big one being that qualified clinical data registries have the opportunity to develop unique measures outside of MIPS CQMs that are subject to MIPS or subject to CMS approval for use, where qualified registries do not have that ability to develop their own measures. Another big difference here is that qualified registries really will have a limited number of measures they support. They do support MIPS quality measures, but you really need to do your due diligence if you're looking into this to see if that registry has all the measures that you need. Qualified clinical data registries really have a more comprehensive list of measures that support both MIPS quality measures, but also programs outside of the MIPS that you could use in different programs if your organization needs those measures. So that's really the big key differences here.
And I want to add, there are things to consider when you want or need to use a registry to submit quality data. If you're in a practice who has limited reporting capability or limited measures on certain collection types, and that's what we talk about, a collection type with MIPS CQMs and ECQMs, you might look at a registry. If you're a provider who has not implemented an EHR into your practice, and so you're working still off a white space, you're still using paper documentation, but maybe electronic billing, you would consider a registry. And then sometimes there's better benchmarking opportunities through the registry than maybe reporting through claims. So that's something to think about as well. I have a couple practices who are using registries, and they are using registries that are associated with their specialty organization. So if they're part of an association such as dermatology, they're using DataDerm. Anesthesia has one as well. There's several registries out there to consider.
And then I just want to add here too, when you work with a Kentucky Regional Extension Center, you get to work with a dedicated, individualized advisor who understands the unique needs that your practice has, your specialty, your patient population, and also your technology setup. So your advisor can work closely with you to explore what CMS approved registries are available, and then help identify that best fit for the work that you're already doing and the technology that you already have.
So yeah, lots of information and with quality and registries. So another category that we get asked a lot of questions on is cost. Cost is that kind of the mystery category of the four traditional MIPS categories. And, you don't get data immediately. You have to wait for it when the performance feedback reports come out in the middle of summer. And so you don't have very much access to that data until later on. So there's some questions about that, and we wanted to talk about it. So I'm going to pass it to Jessica to start us in on this conversation.
Sure. Thank you, Vance. And kind of to your point, yes, it is very much a kind of a neglected category. We've had some of the COVID EUCs. There were some years that were just across the board, cost was not calculated or reported on for the program. So that has created some challenges in getting access to data. Also, because of the EUC flexibility, we saw a lot of clinicians and practices taking advantage of those individual category reweightings as a part of the COVID EUC process. So I think it's been a really long time, probably 2019, if you submitted that year, that you would have some really meaningful data. Now, CMS, with the 2023 reporting year, has provided some feedback to our clinicians and practices so that it can kind of help gather some data on where you're at now because of that big gap between 2019 and 2023. It's really hard to use that older data given the current climate of healthcare. So I think, for the most part, it's really important now for us to start shifting gears and putting that emphasis back on cost. It's 30% of your total MIPS score. And so I think, as individual practices and groups, understanding how you can leverage your cost performance to help improve your overall QPP performance so that you can not only avoid penalty, but hopefully get the max reimbursement or positive adjustment that you can with the program.
Yeah, Jessica, and if I can add, I think a really good place to start with that is kind of looking into the type of clinicians that are in your practice, the types of procedures that they bill for, what specialties do you have represented across your organization, and pull out those cost measures that are going to be possibly that could be attributed to your practice. So if they've been scored on cost, how have they performed historically? Do they have poor past performance? And, like you said, some folks haven't gotten any cost data in the last few years, but we have seen some practices kind of get some information, whether they did the EUC or not, they may have got something back. So reviewing those reports, if you did get anything back, is also a good place to start, just to kind of look at that historical aspect of past performance. And understanding the measures and how the attribution works for those measures. So really digging down into those measure specifications. How is the measure attribution works for that measure, how the care episode is defined. So if there's a measure that you feel is a good possibility that you could be scored on, what are the case minimums, and how does the billing and coding affect that performance? So if you're not billing to the greatest specificity to show how complex the patients that you're treating are within your patient population, it can really affect your performance if that piece of the puzzle is missing when it comes to cost. You can have patients that look like they're not very complex, they don't have a lot going on, but then they go in the hospital and they have a very high cost attributed to them. So just digging into all of that and seeing how that aligns.
Tab, you bring up a really good point there about documenting to the fullest extent. And that's really, with my work that I've done with the QPP program that I've seen, is a real pivotal piece in optimizing cost performance. And it revolves around HCC risk scores and that documented to the fullest extent. It really is imperative that you try to capture that full complexity of your patients on the claims that you're billing out. CMS does take this into account with cost measures and has benchmarks per se with the cost measures and the associated HCC risk factors. If you're really not documenting to the fullest extent and capturing chronic conditions and other illnesses, it can skew your cost data and, like Tab said, really make it look like you're spending entirely too much on your patients that normally wouldn't cost that much. In those cost feedback reports, it does include HCC risk scores, and this is something that your advisor can dive in with you and really give you a better plan for the future when looking at cost data.
Yeah, that's really true, guys. And that's one way we can help our clients is with cost, is we have developed a new tool, a cost analysis tool that we are getting ready to share with our current clients here in the near future. And it really helps analyze your historical cost performance from those feedback reports with that beneficiary level data, that we take that information and we kind of give you an overview of your cost performance, identify the different measures that you were scored on, what that measure specs looks like, what it's looking at, what that score means, and really some outliers of your cost performance of different beneficiary levels, and really kind of does a deep dive into that to give you some sort of a picture of really to how to improve certain measures that you were scored upon. So we're looking forward to that.
Then to dig a little bit deeper into cost. Cost is baked into every track of the quality payment program, not just MIPS. So you might not be scored directly on cost if you're in an APM or an advanced APM, but it's going to be part of that contractual arrangement you have with CMS and the ACO. So when you're in an APM, CMS does look at the cost of care you provide, but how you perform in both quality and interoperability is just as important and often impacts how much shared savings your ACO could earn. Vicki, can you help us elaborate a little bit on this?
Yeah, so what is the APP? So the APP is an advanced payment model, and it is part of the quality payment program. And it's for clinicians and groups within an ACO or an accountable care organization. And they will meet the criteria of a CMS approved MIPS alternative payment model or an APM. So the APP model involves specific levels of shared risk and savings while serving a designated population or focusing on a particular condition or episode of care. The APP is a specific quality measure that the ACO will submit under the quality payment program, and its performance is linked to share savings payouts. So basically, you're looking at if there's better performance results in higher payouts. So it's quite a bit different from traditional MIPS that what you're used to.
So I can jump in here and talk about the APM track. So this is really, CMS's end game and where they'd ultimately like to see clinicians participating in that full shared risk reward model. You can think of this as taking off the training wheels and being fully responsible for the quality and cost of care that you're delivering. Clinicians are given a status of qualifying participant based on how much that they are billing through that alternative payment model and how many of those beneficiaries fall into that. QPs are exempt from MIPS participation, like Jess had mentioned earlier, but there still are the quality performance requirements and cost shared savings and shared risk with CMS in the APM track.
So CMS has created these pathways within the QPP to what they consider as value-based care to meet their Healthy 2030 objective, which was to have all traditional Medicare beneficiaries in an accountable care payment model by 2030. So these are your Medicare patients who are on the traditional fee-for-service Medicare. CMS has said for several years now they want to have them in some type of accountable care model by 2030. Vance, you want to start us off with describing this path to APMs?
Sure. So, we started off that first step, Robin, was traditional MIPS. That is where a majority of people lie currently, is in that traditional MIPS track. And that's really looking at quality and the cost of care. So the next step, CMS kind of is looking at the MVPs to move us towards that APM pathway. So MVPs is that second step. You have 15 different MVPs currently that really look at different populations of patients or maybe a specific types of condition or episodes of care that they look at for those 15 pathways. And it's adopts kind of similar principles and really serves as that as a bridge or that transition to the APM track. And lastly, like Jared said earlier, you know, CMS's end game is that APM track for everybody, or an advanced APM model. And with that, APMs, you're going to have different degrees of financial risk and rewards dependent upon the type of APM that you would be participating in.
Yes, Vince and Robin, thank you for that. I think too, something that we, really want to keep in mind is that CMS does encourage and really has set this very lofty goal to be in some type of an accountable care arrangement for their traditional MIPS beneficiaries. Now, CMS does recognize that if you are a small practice, a one-doc shop, perhaps being a part of an ACO or in an alternative payment model might be very challenging for you. And so they have left the APP or the MIPS value pathway as an option that is open. So if you're typically I think really the future, what they're forecasting is more of our small practices that haven't joined with a larger organization would still stay in those MVPs, but they're really pushing those mid-sized health systems, larger offices to collaborate with other organizations to be able to join and form ACOs and be a part of that, APM track or the APP, the the APM performance pathway. And so one of the things that we do as advisors is we do a lot of education with our practices because we recognize that the alphabet soup of ACOs and APMs can get a little overwhelming. And so, if that's something that your practice or organization is considering, we work with you on reviewing different components of the ACO that you're looking at or a particular model that is coming down the pike to see if that is something that is interesting to you and meets the scope of care that you are providing. So we don't make any specific recommendations on ACO selection. We are sort of agnostic in that area. However, we want to make sure that you know the right questions to ask. There is a lot of reward that can be available from an ACO, but there is also a lot of risk that can be involved. And I think we all agree here that it's really important for our practices here in the state to go into these type of payment arrangements with their eyes open and to know where their responsibility is and how that risk, are you able to absorb that risk? And so asking those questions with either the ACO participant or asking that accountable care organization itself, how they structure their risk and the responsibilities to those individual clinicians or those practices that are collaborators within some of these models is very, very important. So that's some of the different things that we help you with. One of the other things is we actually have several clients who are a part of an ACO, and we continue to work with them. They really are focused on their quality improvement and optimization, and a lot of times they actually do a separate submission from their ACO just to be able to maximize any kind of potential reimbursement. So if you are a part of an ACO and you want to make sure that you are meeting your quality and exceeding that so that you can be a higher contributor to that shared savings, definitely we are here to partner with you in that regard. Now, talking about audit preparedness, we're kind of shifting gears, right? Because 2024 is drawing to a close. And so I think it's always important to highlight some of the preparedness pieces. No one really likes the word audit, but CMS does it. They actually have already started the audit process for the 2023 performance year submissions. If you are up for an audit, you will actually receive some information from CMS, and Vance is going to talk us through a little bit about what and how you are notified of an audit in the event that it occurs.
Yes, this is the most exciting thing people look forward to is the audit letter. So You will officially get an audit letter through your email account that you have registered with the HARP through your QPP portal. So those that are listed as security officials will be emailed notification. Within that, they will be given specifics and different attachments of the requirements that you will have to do. I will let you know, currently there are 2 different phases to an audit. You have to submit the first section of criteria that the CMS provides for you to submit to them within a time frame. And you have to get both of those phases done within a specific time frame in order to meet that audit requirement. And I'll let Vicky kind of continue this conversation.
So when can a practice be audited, and then for how long? So CMS reserves the right to audit up to 6 years following the performance year that you submitted for. So that's quite a long time that you would need to retain documentation for that full 6 years. If you are audited and they request information, retaining that documentation for 6 years is going to facilitate a more smoother audit process. So be sure and keep all your documentation for at least 6 years. And Tab, what are some tips for retaining some audit documents?
Sure, thanks, Vicki. So I think a good place to start is a succession plan. So if the security official for your organization's on leave or transfers to a different company, do you currently have a process in place to make sure that that transition is smooth and timely? It's really good to have that down in a policy, and everybody that's involved really knows how that process is supposed to work. Making sure that everybody has those clearly defined roles, everyone understands their part. Also, your documentation should be kept in a safe location, but it's also going to need to be easily and readily available to those who are going to need it in case of an audit. Also, we at the REC always recommend that folks keep a physical copy as well as an electronic copy of all of their documentation when it comes to your submissions. So you can keep those in a binder. We recommend that you keep all your agreements and addendums, any screenshots that you've taken throughout the year, reports that you've used for your submission, any emails that you've received related to your submission, or anything that you have reached out to CMS for, like questions around certain categories or things that are happening within your practice that you have questions about. It's really important that you keep all of that information together. You definitely want to have proof of any conversations that you've had regarding anything with reporting to the quality payment program. So in addition to that physical documentation, we talked about the electronic copy. You can keep that on a secure server, on a shared drive. You could even keep that in a cloud server if it's HIPAA compliant, of course. And you would also need to have those just in case, what if a fire happened and destroyed those physical copies that you had? Any loss of records due to miscommunication and things like that. So it's always a good idea to keep that documentation in both ways. So if one fails, you've always got that backup copy that everybody can have and access in a time of an audit.
So we threw a lot of information at you guys in just an hour. We could probably make this webinar 3 hours and still barely scratch the surface with QPP. So saying that, don't stress, we're here to help. And there are some great benefits with partnering with us at the REC here. We are really able to review eligibility data constantly. We always take a look at that a few times throughout the year to check those providers that may fall in and out of eligibility over the course of the performance year. There's no need for you to go and read the 3,000-page 2025 fee-for-service final rule that just came out. We are currently underway doing that. We read both proposed rules, final rules, and really try to stay up to date on all legislative updates that are coming out. We can meet with you, quarterly, monthly, bi-weekly, and give you those performance updates for the program. We are happy to take deep dives into your data, into your EHR system, do patient drill downs with you. And then, Vance had mentioned our new cost analysis tool. We also have a really great gap analysis that we provide you with. And it's really good at giving you the best prediction on scores throughout the year. And I'll turn it over to Alicia to kind of wrap us up here.
Thank you, Jared. I think I just really want to highlight the individualized advisor. So when you work with the REC, you get an individualized advisor who really is going to understand your practice and then your specific challenges, and then tailor that support to meet your unique needs. So an example, we talked a little bit about the final rule coming up. So we do legislative updates, but really how are those updates from the final rule going to individually impact your practice? And then things like diving deeply into your own data and your workflows and finding the solutions that best support your unique goals.
All right. Thank you all so much for lending your expertise and giving some of the highlights and some of the important considerations to get us not only squared away for 2024, but also some of the things that we just need to look at as far as the future pathways of the quality payment program. Now, I did just want to touch on, we do have some educational webinars. We actually provide educational content that's specific for our clients only. We generally release at least one webinar that's either live or pre-recorded to our clients every single month. So you're always getting up-to-date information, as well as that at-the-elbow support from your monthly meetings with your expert advisor here at the REC. I did want to go ahead and also announce that we have a couple things coming down the pike. We are going to be releasing, and it should be on our website to find it. We are releasing an overview of the team model APM that has just been recently announced. It was actually part of the IPPS final rule. And so this is going to be a requirement of an APM model that is going to be required, of health centers, hospitals across the state. There are a select handful, about 17, 18 or so, in the state of Kentucky that are going to have mandatory participation. So please take a look at that recording whenever it becomes available on the Kentucky REC website and see how it could potentially impact your organization. Additionally, we don't have this on this particular slide deck, but we are doing a QPP final rule webinar in January. It'll be on January 21st at 12 p.m. Eastern. And we will send out more information on the sign-up link to that particular webinar that is going to be open to the public. But if you are interested in viewing some of our client-only content, please feel free to reach out to the Kentucky REC. Email, give us a call, and visit our website. We are more than happy to help answer your questions and to see what we can do to help support you and the care that you're providing to your fellow Kentuckians. And I just want to offer my thank you to Jared, Alicia, Vicki, Robin, Vance, and Tabitha for sharing this with us today. Thank you all.